Regarding the location, the most common location of a breast cancer is the upper outer quadrant, accounting for 50% of the breast cancer cases. So the most common location is the upper outer quadrant, followed by the central portion or the subareolar area, accounting for 20% of cases. The lower outer quadrant, the upper inner quadrant, and the lower inner quadrant, each accounting for 10% of cases. About 4% of women with breast cancer have bilateral primary tumors or sequential lesions in the same breast. Invasive ductal carcinoma is the most common histologic subtype of invasive breast cancer, accounting for 70 to 80% of cases, and it's also called carcinoma not otherwise specified. Usually, this lesion is preceded by precancerous lesion called ductal carcinoma in situ. Clinically, the tumor presents as mammographic densities during the regular screening or as a hard palpable irregular mass. Usually, this tumor shows positive expression of ER and PR and negative expression for HER2. Invasive ductal carcinoma is graded into three main groups according to certain histologic features. We have three histologic features that are used to classify invasive ductal carcinoma into the main three grades. The first one is the tubular formation. The second is the nuclear pleomorphism. And the third is the number of mitoses. This figure shows the three histologic grades. So if you look from the left side here, this represents a grade 1 well-differentiated carcinoma, because it shows frequent tubules, as you can see here, which is the first feature that we rely on, and also mild atipia, so the cells are a little bit monomorphic and there is no frequent mitotic figures in this tumor. So this is classified as a grade 1 well-differentiated breast cancer. Look at the figure in the middle here. This one is a grade 2 tumor, which means moderately differentiated breast cancer. There is less tubular formation than the first tumor, and there is more solidness of the tumor cells, and there is more atypia. Look at the third figure here, the one at the right side. As you can see here, this is a grade 3 tumor, which means poorly differentiated carcinoma, because the tumor cells are mostly infiltrating as sheets and there is less tubular formation, if any. I cannot appreciate any tubular formation in this figure. And here is a higher power view showing the atypia and the frequent mitosis. Invasive lobular carcinoma is another histologic subtype of breast cancer, and this histologic type accounts for about 10 to 15% of all breast cancer cases. This tumor is preceded by a precancerous lesion in about 2/3 of the cases, which is the lobular carcinoma in situ. The tumors tend to be multicentric and bilateral in about 10 to 20% of cases, and presents clinically as a palpable mass or as a mammographic density. In terms of histology, invasive lobular carcinoma shows something called single file, where the tumor cells invade the stroma individually, so as single cells, and this is what we call single file, and this is characteristic for the invasive lobular carcinoma. This happens due to the loss of adhesion in the atypical lobular hyperplasia and lobular carcinoma in situ and the invasive lobular carcinoma, and this is due to a dysfunction in the E-cadherin. The E-cadherin, as you may know, is a transmembrane protein that contributes to the cohesion of normal epithelial cells in the breast and other glandular tissues. So the loss of the E-cadherin will result in loss of the junction between the cells, and so the cells looks like that they are infiltrating individually, as we see in the invasive lobular cancer. Regarding the receptor profile, lobular carcinoma usually shows positive expression of ER and PR with negative expression of HER2, or maybe it can be seen in rare cases. This figure shows the histologic findings in invasive lobular carcinoma. As you can appreciate here, we don't see the tubular formation اللي لاحظناها في الانفيزيف ductal carcinoma، بل على العكس الخلايا هنا موجودين بشكل منفصل عن بعضهم البعض. So they are present individually, infiltrating individually as a single file, and this happens due to the loss of the E-cadherin protein. وبالتالي ما رح يصير في عنا tubular formation مثل اللي شفناه في الانفيزيف ductal carcinoma. Breast cancer can spread through the lymphatics and through the blood, and the majority of breast cancer gets metastasis to the regional lymph node. So first of all, the lymphatic drainage goes to 1 or 2 sentinel lymph nodes in the axilla. And if these lymph nodes are negative, then the remaining axillary lymph nodes are considered negative. That's why it's very important to take a biopsy from the sentinel lymph node. And this is a standard procedure to assess the regional lymph node involvement. So usually after the diagnosis of a patient with breast cancer, the surgeon will take a biopsy from the sentinel lymph nodes, which are the first 1 or 2 lymph nodes that receive the lymphatic drainage from the breast, and they send it to the histopathology lab. If it turns to be negative, then they consider that the axillary lymph nodes are negative, and if it turns to be positive, then they're gonna excise the rest of the lymph nodes. Regarding metastasis, the favored site for metastasis are the bone, lung, skeleton, and the liver, and also the adrenal. Less commonly the brain, the spleen, and the pituitary. In this slide and the next slide, we're going to be discussing the prognosis for a female with breast cancer. The clinical outcome for a woman with breast cancer can be predicted based on molecular and morphologic features of the cancer and the stage at the time of diagnosis. So in this slide, as you can see, 2 main factors are involved in determining the prognosis of your patient. The first one is the tumor stage. And the tumor stage, according to the TNM system, includes the T stands for the size of the primary tumor, and if the tumor is invasive or in situ at the time of diagnosis, the presence or absence of lymph node metastasis or involvement and the number of the involved lymph nodes, and the presence of distant metastasis plus the presence of local skin involvement and skeletal muscle involvement. The histologic grade, as we discussed, it depends on the tubular formation, the pleomorphism, and the mitosis. Another interesting point that tumors that are associated with high proliferative rates may respond very well to the cytotoxic chemotherapy. The histologic type of breast cancer can also affect the prognosis because certain histologic subtypes are associated with better prognosis, like mucinous and the tubular breast cancer, while certain histologic subtypes like inflammatory carcinoma are associated with poor prognosis. The expression of ER, PR, and HER2 are very important factors that may influence the prognosis and the treatment plan for your patient, because the expression of ER and PR by the tumor cells means that this patient is eligible for the anti-estrogen therapy, and this therapy will inhibit the growth of the cancer for many years. Furthermore, it's very important to evaluate the HER2 receptors for your patient, because evaluating the expression of HER2 receptors in the tumor will predict the response of the tumor into a monoclonal antibody used in the treatment of breast cancer and called Herceptin. Herceptin targets the HER2 receptors to fight the tumor cell growth, so this will decrease the growth of the tumor cells and also stimulate an immune response to destroy the tumor cells.